Hi, good afternoon, everyone. I hope I'll be able to address some of your questions and give you some useful information on medical cannabis. There's been some pretty exciting developments in the last year or two in particular, not to mention the fact that the recreational supply was legalized last month, which has changed the landscape a little bit. Just to go over the scope of our discussion today, I'm going to give you a brief history of cannabis research, get into the pharmacology of the known cannabinoids as we know it at this point, go through the evidence and recent reviews of its therapeutic use, attempt to determine its place in therapy, or at least look at the landscape around this, talk about the medical cannabis program and some of the implications of legalization, both positive and negative, go through a case study to try to pull some of this together, and then give you some resources at the end that might be useful to you. So this is the mandatory conflict of interest slide in my presentation. I have none to declare. My partner formerly held shares in Aurora Cannabis, which he actually sold in August, given all the uncertainty in the market. Aurora was kind of the inspiration for the title of this talk when we were looking at this as a family in terms of an investment opportunity. The term Cheech and Chong meets Pfizer came up as a description of what we were seeing. It might be true of some of the other suppliers, I'm not sure. But one thing I did want to mention is my qualifications as a speaker on this topic. I have 37 years in hospital pharmacy practice, including some encounters with patients who used marijuana, either recreationally or for medical purposes. And I have had the honor of helping them to manage their withdrawal in hospital or their use of their products in hospital, including one pediatric patient that I saw in my practice at Lionsgate Hospital who was using cannabidiol oil to help control seizures along with other medications. What I try to do for these patients is to advise them and help them manage their issues around their cannabis use by making the effort to listen, endorse their experience with it, avoid passing judgment while working with a complete absence of health authority policy around the use of cannabis during a hospital stay, which was definitely a challenge. What I'm going to try to do for you today is to take an academic detailing, even-handed approach to this topic, which I hope will be helpful to the audience. We've already heard from the proponents of cannabis use who assert that cannabis is good for everything and probably even cures cancer, and from the opponents who admonish us that it's not good for anything and it's dangerous. So I'm hoping to walk right up the middle here and hoping that will be useful to you all. So, Sir William Osler, the famous Canadian physician, who was honored with a knighthood, is one of my favorite generators of medical quotes. And I think these two in particular apply to our topic today and to some of the current attitudes around the medical use of cannabis. Given my background in specialty pediatrics for years at BC Children's Hospital, I might be a little bit more comfortable proceeding with treatment based on more limited evidence because I was often in that situation in pediatrics. So it may have helped me a little bit in getting my head around this topic as well. Okay, so we're going to talk a little bit about the history of medicinal cannabis use. It goes way back, as you'll see from this slide. In China and the Middle East, cannabis and extracts were used to treat neurological diseases, and there's a historical record of a high CBD extract of cannabis being used to treat epilepsy in the son of the caliph back in the 1400s. Apparently, Queen Victoria used cannabis in some form to treat her frequent headaches. And it's interesting, given all this background, that the research into the pharmacology of cannabis and the medicinal chemistry was very late in coming in comparison to things like opium and cocaine. Going back about 50 years or so, the National Institutes of Health in the US was unwilling to provide research grants into the pharmacology of cannabis, but when its use became common in the late 1960s, there was a sudden interest in its effects. and also its legal status. And regarding that aspect of it, its designation as a Schedule I drug in the US, which means it's of high abuse potential and has no therapeutic use, seemed more politically motivated than it was based on a public health risk. So just to round out the history section of this, I'll talk briefly about the history of cannabis research. As we mentioned, it kind of came along a bit late. One of the premier researchers in this area is Dr. Raphael Mechoulam, who still is at the Hebrew University of Jerusalem and is a professor of medicinal chemistry there. He's the eminent pioneer in this area and discovered THC and CBD as active entities in the 1960s. Much later, about 1992, he identified the endocannabinoid system in vertebrates and the two endogenous compounds that act in the endocannabinoid system. And these are anandamide and 2-AG. The system plays a role in regulation of mood, memory, and sensation of pain, and he did quite a few pharmacological studies in animals in particular to describe this. The initial research material he had, interestingly enough, was extracts of hashish that was smuggled in from Lebanon and seized by Israeli police. Later, the Israeli Ministry of Health stepped in and authorized a supply, since this wasn't exactly a legal route to getting the raw material for his research. Interestingly enough, Dr. Mechoulam says he has never used cannabis, which is also true of me as well. Okay, next slide here. Okay, so what do we know about the pharmacology of cannabinoids? One of the really big positive steps that's happened just in the last few months is that the Canadian Pharmacists Association actually added a monograph for medical cannabis to the Compendium of Pharmaceuticals and Specialties, which is our main source of drug information from companies that manufacture it, and Health Canada approved monographs on things that are prescribed in Canada. So this was a huge development and certainly a huge help to me in terms of preparing this talk as well. There's a lot of information about the pharmacology in that monograph, and I would direct anybody who's tuning into this webinar to have a look at it. The mechanism of action of the cannabinoids that we know of, and the main pharmacologically active ones that we're sort of clear on at this point, are delta-9 tetrahydrocannabinol, or THC, and CBD, which is cannabidiol. I resisted the temptation to show you a synapse here because it probably wouldn't have looked particularly good on the screen. And I would have had to apologize to you for its complexity. So we're going to skip that step. And we're going to talk about it in a little more sort of qualitative aspect. So the pharmacology of the cannabinoids is in terms of what it does, is relax, eat, sleep, forget, and protect. And those are kind of the actions of the cannabinoids as we know them at present, thanks a lot to Dr. Mechoulam's research. The forget would seem to be a negative. However, think of how important it is to be able to do this and how chaotic your brain activity would be if you remembered everything. I saw a talk by Dr. Mechoulam, and as he described it, imagine if you walked through a shopping mall and you remembered every single face that you saw in your trip to the shopping mall. Your brain wouldn't be able to function if it couldn't edit things out. So forgetting is obviously kind of a key activity the brain needs to participate in. So we know that THC works on the known CB1 and CB2 receptors, and it has similar actions to the endocannabinoids that I mentioned. The CB1 receptors seem to be most abundant in the brain, and anything that actually stimulates those receptors, so agonists, regulate the presynaptic release of most, if not all, other neurotransmitters. In other words, this is the system that regulates a lot of the other neurotransmitters that we already know a considerable amount about, which is interesting. CB2 receptors seem to be mostly in the immune cells, and the cannabinoids reduce the release of cytokines and chemokines. Now, cannabidiol is kind of interesting in that we don't actually know its mechanism or what receptors specifically it hits. It doesn't seem to affect the CB1 and the CB2 as much. But what we know about it is that it seems to modulate THC effects and potentially reduces pain, inflammation, nausea, anxiety, and seizure activity by some other mechanism. The other thing that's interesting about the pharmacology is the entourage effect, as it's known. It definitely needs a lot of further study, but the theory is that compounds like flavonoids and terpenes that are in the plant may actually enhance the pharmacological effects or reduce the adverse effects of the active cannabinoids that we know of. Some of the evidence that supports this is that dried cannabis or extracts of different strains of the plant. So there's sativa and indica, and there's also hybrids between those two can have noticeably different effects. For example, there's actually been some research that has shown that medical cannabis users who are people with chronic pain tend to show a strong preference for indica strains. And that would make absolutely no sense if we're just looking at the pharmacologically active compounds and there isn't something else going on. So that's definitely something that needs further study, and there's probably a lot of promise in that in terms of determining plant sources of active compounds and product selection for people who are going to use it for things like chronic pain, for example. Okay, so a little bit more about the pharmacology. This is the pharmacist slide. The pharmacokinetics, and any pharmacist who is tuning in will see the absorption, distribution, metabolism, and excretion and immediately recognize that. It's all pretty self-explanatory on this slide. Some of the things to note about the absorption is the vast difference between using vaporized or smoked, which obviously we wouldn't recommend for most people, the smoking option. But it's the absorption of the active compounds is much more complete by inhalation. The onset's faster, the peak's faster, and the duration is shorter. In comparison to oral, which is way less well absorbed, has a slower onset, it can be quite delayed in some people and quite variable between individuals too. It peaks much later and the duration is much longer. And it also tends to be longer in children than it is in adults, which is also interesting. When taking it orally, food can alter the oral absorption considerably. It can delay it and reduce the absolute amount that's absorbed too. So in people who are taking it orally, consistency is the best approach in terms of taking it on a full or an empty stomach. And the other complicating factor is that THC tends to delay gastric emptying as well, which makes things even more variable between individuals. So because of all these oral absorption problems, some other routes are being investigated, like transdermal routes, so applying it topically as a patch or an ointment, and there are some topical preparations that are out there already, but not on the medical program. And also giving it buccally, in other words, inside the mouth, held inside the mouth. And yeah, next slide there we are, sorry about that, or sublingually. And people who take oral extracts often will hold it under the tongue for a minute or so to try to get some of that more rapid absorption. And that bypasses some of the metabolic routes as well. So how these active compounds are distributed in the body is interesting. THC in particular goes into fatty tissues preferentially, and also in areas that have very high blood perfusion, so heart, lung, brain, and liver. So a lot of tissue deposition, and that we'll get into that a little bit more later in terms of the implications of that. One of the problems with taking it orally is that all of the blood that comes from the gastrointestinal tract, of course, goes through the liver, and it gives the liver an ideal opportunity to extract and metabolize as much of this as possible as well. So that's one potential limitation of taking it orally as well. And that's why they're looking at other routes of administration too. And those of you who are familiar with liver enzymes and some of the variability in them, you'll see some of the isoenzymes there that are involved in metabolism. There's one active metabolite of THC as well that has some of the same activities. So it's not just the THC itself that has pharmacological activity. And any of you who are familiar with the enzymes will know that there are other drugs that interact with these as well, and we'll get into that a little bit later too. So how are these compounds cleared from your body? Most of THC and its breakdown products are cleared out through the gut, some through the kidneys as well. The half-life of THC can vary from about 1 to 3 days in people who only use it occasionally to 5 days in chronic heavy users. And this is probably THC leaching back out of the tissues that it's distributed to. And THC can persist for 1 to 2 days in the urine easily. It can be detectable in small amounts for up to 13 days. It can even persist for up to 5 weeks if a person is a long-term heavy daily user of a product with THC in it. So it's pretty complicated stuff. Okay, so that's probably enough about the pharmacology. Now let's get into the evidence a little bit. So one of the real game changers for me in terms of my interest in medical cannabis and its potential was the report that came from the National Academies of Science, Engineering, and Medicine in the US in January of 2017, where they did an exhaustive review of the literature and concluded that there was reasonable evidence to support its use for the first 4 indications that you'll see listed there. And then the use of pure CBD for treatment refractory seizures has been evaluated in clinical trials that were published since the National Academies review last year. And you'll note that the FDA has approved CBD based on these clinical trials. So it's just awaiting legislative changes in the US, and it will be available as a prescription drug for treatment refractory seizures. And it's been evaluated in clinical trials for Dravet's and Lennox-Gastaut syndromes. So 2 very difficult to treat etiologies of seizure disorders. The other thing, as I mentioned briefly earlier, is that the Canadian Pharmacists Association has really got out ahead of this issue as well and provided some good comprehensive evidence-based information on medical cannabis, which they started doing in January of 2018, and then that progressed to them putting a monograph in the CPS in April of this year as well. And I'll concentrate on some of the resources that the CPHA has at the end of the talk for people who want to check them out. Okay, so a lot of this prescribing information comes directly out of the CPS monograph. So it is a really good source of information. I would highly recommend people to have a look at that. You'll see that this is laid out very similar to a usual product monograph, which makes it quite useful. Some of the reasons to not use medical cannabis, obviously, are known sensitivity to the plant, or people who've had adverse experiences with some of the prescription cannabinoids like nabilone or Sativex, for example. There's still concern about its use in pregnancy. There's a potential risk of reduced fetal growth, sudden infant death syndrome, and neurodevelopmental effects. It's difficult to separate this out from the effects of other substances that people may be using if they're using recreational cannabis, and most of this information has come from that source. So it's worth keeping that in perspective. We will find out more about this, I think, as we use it more medically and we have more sort of pharmacologically related products that are being used for various indications. Likewise, in breastfeeding, some of the adverse experiences may have been due to other substances being used at the same time, but it is known that the cannabinoids accumulate in breast milk due to lipid solubility. So it's wise to avoid using cannabinoids in breastfeeding if at all possible. In pediatric patients, it's still considered risky to use cannabis for those great or less than 25 years of age due to the potential for ongoing brain development up to that age, except for treatment refractory seizure disorders in children and adolescents where the benefits would outweigh the risks. So warnings or precautions that are associated with medical cannabis use, major ones are to avoid if there's a history of psychosis or schizophrenia, a personal history. Family history is maybe a little bit more controversial, but it's still something to keep in mind. People who have a history of substance use disorders are probably more likely to develop a cannabis use disorder if they use it therapeutically, so a potential risk, and also the issues around driving. And the recommendation in the monograph is to avoid driving within 4 to 6 hours of use, or to wait at least 8 hours if any euphoria was experienced from the THC content. Drug interactions, we mentioned some of the liver isoenzymes that metabolize this also metabolize other drugs. So cannabis can affect the activity of these enzymes and can also compete for the activity of these enzymes. The fact that the active components of cannabis increase or actually inhibit cytochrome 1A2 can increase levels of things like amitriptyline and duloxetine, which are 2 medications that may also be used by people who are need treatment for chronic pain. And estrogens are also on this list, and any other 1A2 substrate could potentially be affected. CBD has been shown to boost the active metabolite of clobazam in some of the studies that have been done in children with epilepsy. Obviously, any other central nervous system depressant or any other medication with similar adverse drug reactions, you can see an additive effect with cannabis. So that's pretty straightforward. Oops. I'm having trouble advancing the slides here. There we are. Okay. All right. So dosing and administration, this is going to look very different to what most people are used to seeing come from a CPS monograph, but nonetheless, there is some very helpful information in here in terms of how to initiate treatment with medical cannabis and how to adjust the dose. First of all, let's just state at the beginning that the requirements vary widely between individuals based on their previous experience with any cannabis products, the route they choose to use, so vaping versus oral extracts of cannabis, the potency of the product that they're using, the ratio of THC to CBD in the product, and genetic variability, which obviously affects any drug. We're never entirely sure how somebody's going to respond to a drug, and there can be a lot of variability between individuals, and this is no exception. Adverse effects can be reduced considerably by starting with a high cannabidiol and low THC product or regimen. So this is when a person who's starting out in medical cannabis for the first time, this recommendation should be taken quite seriously. Further adjustments are based on tolerability and effectiveness, basically. So people can try a different product for extracts and oil of known strength or a different strain. Cannabis sativa tends to be more stimulating. Cannabis indica tends to be a little bit more calming and relaxing in most people's experience. And there's also several hybrid strains that various licensed suppliers have developed that try to capitalize on what we know about the entourage effect. So initial dosing, your mantra here is start low and go slow. And there are actually some good specific instructions that we'll go into in a moment that are provided in the CPS monograph that are quite helpful. This minimizes adverse effects and allows some tolerance to develop as the person is titrating up their dose to something that seems maximally effective. So the dose adjustment that is suggested is that if the patient is going to use the vaping route, that they start with 2 inhalations in a 15-minute period, then increase the number of inhalations by 1 every 15 to 30 minutes until symptom control is noted. So this is what they would do with their first dose. And For extracts and oil, taking 0.1 milliliter of their extract every 30 to 60 minutes until the desired effect is a reasonable approach to determining the effective dose. And this takes into account the fact that it takes at least 30 to 60 minutes for an oil dose to kick in because of the delay in absorption. So typical ongoing use for medical cannabis is somewhere between 1 and 3 grams of dried cannabis per day inhaled. So that would be people who are vaping, hopefully not smoking. Oral use is about 2.5 times this amount and is much less predictable. So some people do actually use dried cannabis orally. They'll bake it into baked goods or make teas out of it or whatever. But since 2015, the Health Canada program has allowed oil extracts of cannabis as well, and they're of a known strength of THC and CBD, which is quite helpful. If a person misses a dose, each person has to determine their own schedule based on the duration of effect. So a missed dose should be taken as soon as it's remembered, basically. And this is often what we'll advise for prescription medications as well, unless there's a reason not to. But you'll get the impression from this slide that the patient really has to determine what works best for them. Because everybody's duration of action is a little bit different, some people will be able to take it every 12 hours. If they're taking it orally, some people will have to vape every 2 hours. So it's something that the patient needs to determine for themselves, what they get the most benefit from, and what's most convenient for them in terms of a dosing regimen and what their actual effective dose is. Okay, so adverse reactions and overdose effects. I've listed a whole bunch of adverse drug reactions here. These are in the CPS monograph, and I won't go into detail on them. You can see them for yourself. I will talk a little bit about overdose. The signs and symptoms are basically more pronounced adverse drug reactions as per the above list. Possibly accompanied by hallucinations, bizarre behavior, psychosis, and chest tightness seems to be a feature in people who have overdosed who have limited experience with medical cannabis. So the risk is increased with oral use due to delayed onset. So people are more likely to take more than their effective dose if they're not experienced with it, and they take it by the oral route, and then you get delayed oral absorption and it kicks in several hours later with a much greater effect than you intended to have. That's one reason why people need to be cautious in how they titrate up their dose of medical cannabis if they're taking it by the oral route. And if people are using it recreationally by the oral route and they have limited experience, they need to be quite cautious with it as well. So managing an overdose, it's basically supportive and symptomatic treatment. So reassurance, keeping the person in a fairly quiet area, monitoring their vitals. And if the person's taken it orally, activated charcoal can be given, as it could be given for some other overdoses, because there could still be a lot of active compound in the gastrointestinal tract, and you can reduce the absorption of that. If the person is really agitated, apparently benzodiazepines are safe to use to get the person through the most difficult parts of the effects. You don't see abnormal neurological findings usually in adults, but they can be more common in children. So things like abnormal movements and those kind of things can happen if children get into a supply of marijuana, medical or otherwise. So let's get down to our biggest topic here, and that's what we know about the place of medical cannabis in the treatment of chronic pain. So the Canadian Family Physician Clinical Practice Guideline came out earlier this year, and it is a guideline for prescribing medical cannabinoids in primary care for chronic pain and some other indications as well. So they had a decision tool that was part of the package in these guidelines that mapped meaningful, which was defined as about 30% or greater pain improvements for 7 commonly used medications for neuropathic pain based on a systematic review of the literature. And interestingly enough, despite the fact that they included the medical cannabinoids, so this would be things like nabilone and Sativex in their evaluation, they recommended against medical marijuana. And they partly justified this by their assertion that the products were of unknown content and strength and that smoking was unsafe, and that's pretty obvious. But the fact that oral extracts of known CBD and THC content have been available by the through the Health Canada program since 2015 apparently wasn't considered by the authors. So do keep that in mind if you decide to look at these guidelines. So they suggested that the prescription cannabinoids be considered for those who have tried at least 3 other medications and have either had little benefit or were unable to tolerate them. So they looked at nabilone or nabiximols, which is Sativex, and it's a 1-to-1 THC to CBD ratio for neuropathic or palliative pain management, or nabilone for chemotherapy-induced nausea and vomiting. So those were the things that they actually evaluated in their guideline. So in trying to sort all of this out myself, and hopefully this will be a benefit to you as well, I tried to think of all of the things that a patient would have to think about in examining medication choices for chronic pain. So these are the factors that they would need to consider. What might go right, in other words, pain relief, what may go wrong, in other words, adverse reactions, what they can expect if they have to stop the medication, how much will it cost, and how much will it impact their life in other ways as well, right? So these are all things that a patient would need to consider in deciding what to try first, or if that's unsuccessful, what to try next, etc. All the guidelines addressed was pain relief, but this is only one aspect of the decision. One of the problems I encountered in this is that there's serious limitations to the data on the effectiveness and adverse effects of cannabinoids as they compiled them in this document, because they didn't consider the medical use of cannabis plant products, and that might be quite distinct from the pharmaceuticals that are available that are cannabinoids. So note that the cannabinoids like nabilone and Sativex, there's no opportunity to adjust the CBD to THC ratio, and in fact nabilone is basically pharmacologically THC and has no cannabidiol effects associated with it at all. So the pain reductions you see in the first column here are estimates from the Canadian Family Physician Guideline, which was actually more of a review of the literature than with recommendations. You'll notice that for amitriptyline, it says about 25% of patients would get about a 30% pain reduction. This is probably an overestimate, because it is overall considered less effective than things like venlafaxine and duloxetine. And it's also quite a bit less well tolerated in terms of adverse effects, because along with some of the similar effects to things like venlafaxine and duloxetine, so the serotonin and norepinephrine effects, it also has anticholinergic effects. So things like dry mouth and constipation, risk and overdose and that sort of thing are considerably different and more significant than with venlafaxine and duloxetine, which are the other antidepressant type drugs that are on this list. So that's something worth keeping in mind. The numbers needed to treat, and this is kind of put loosely under the functionality column, so pain relief potential versus adverse drug reaction potential, that's in the last column, are for about a 50% reduction in pain, or in some cases they're based on studies where it was the patient's global impression of change. There's very weak evidence for either one with venlafaxine, which is interesting because we still do use it for chronic pain. So if you look at the big four here, which are basically venlafaxine, pregabalin, gabapentin, and duloxetine, at least 80% of people taking one of them experience one side effect that's quite troublesome. So dry mouth, sedation, and constipation are most common for all of these. Plus, as I mentioned, for venlafaxine and duloxetine as antidepressants, they have some of the serotonin and norepinephrine effects. So things like headache, nausea, insomnia, and increased blood pressure are quite common for those two particular medications. And then you'll notice that I've got cannabinoids and cannabis at the beginning, where a lot of the information we have about functionality really is either missing, or it's based on experiential studies of people who've obtained their own medical cannabis. So the products used are all over the map, and it's a severe limitation to being able to quantify this and compare it to other things. So basically a big question mark in terms of how much pain reduction you get and how much functionality you get. So I think that's why a lot of people are trying it and seeing for themselves. So this is the second half of the table. This is my attempt to sort of look at some of the other things that a patient would need to consider. So the withdrawal effects, this is basically what the patient needs to know. Okay, what if I have to stop this? How much of a problem is it going to be trying to get off this medication and onto something else? We all know about opioid withdrawal, so I won't go into any more detail about that, but it's certainly significant. With any of the antidepressant type medications, so venlafaxine, duloxetine, or amitriptyline, there is definitely significant withdrawal effects. There was actually a recent review by the Therapeutics Initiative at UBC that suggested that before patients go on antidepressants, they should actually sign an agreement similar to an opioid agreement that makes it clear that they understand that there will be withdrawal effects if they have to discontinue them. And they can be quite prolonged for some people. On average, they probably persist for a couple of weeks, but they have some quite unpleasant effects in withdrawal. And they estimate that one-third to two-thirds of patients will have a significant problem with withdrawal, and they'll be quite uncomfortable through the process. It's a little more questionable with things like pregabalin and gabapentin, but we won't go into that too much. Pregabalin, I could find no information on, and gabapentin, they suggest that you withdraw that slowly as well, because patients can have confusion, irritability, tachycardia, sweating, etc., and the withdrawal should be over at least a week, if not longer. There is definitely a withdrawal syndrome for cannabis, and I've kind of extended that to cannabinoids as well. And I have seen cannabis withdrawal in practice. Patients who are daily users who come in for surgery or often have a lot of difficulty with pain control post-op and can feel quite anxious, and that seems to be one of the major features of it. So if it's abruptly reduced or stopped, anxiety is definitely part of it, and there's a bunch of other symptoms that are fairly common, and they appear in 1 to 2 days and tend to peak at 2 to 5 days and resolve in 1 to 2 weeks. And I've been put in the position of advising a few patients who've come in for orthopedic surgery after injuries, some of whom have been from Whistler and have been heavy users of cannabis on a regular basis, that realistically you're probably not going to feel like yourself until you go home and you go back to your usual marijuana smoking. And that's just being realistic with them. And pain control was a real problem for them because they were suffering a fair amount of anxiety not using their cannabis on a daily basis. So I've outlined some costs as well, and you can see they're all over the map, and some of these things are quite expensive and not covered by pharmacare. And that is true of medical cannabis as well. There are some extended benefit programs who have some leeway for using some of your health spending account to cover the cost of medical cannabis, but I think that's about as far as it's gone at this point. And then a couple of other things that people need to think about because of the non-prescription status of medical cannabis. It's in a gray area between being prescription and being a recreational substance, unfortunately, which means that you cannot travel outside of Canada with it. We're still trying to answer the questions around driving, and even states in the US that have legalized recreational supply are still wrestling with the issue of how to regulate driving in people who are using cannabis either recreationally or medically. So that's something we're going to have to come to terms with in this country as well. So people need to think about some of these issues as well, and particularly travel to the US. If you even admit to having used it either medically or recreationally, they can deny you entry at the border. So something for people to take into account when they decide what to do. Okay, so as everyone knows, we have legalized this substance as of October 17th of this year. And I won't go through all of these in detail, but these are all just things to think about in terms of the changing landscape around the recreational supply, and some of the things that might be negative consequences and some of the things that are potentially positive developments from having cannabis legalized in Canada. One of the things that we've talked about quite a bit at Pain BC is the people accessing the recreational supply and using it for medical reasons, because they don't have to get an authorization from their physician, and some of the implications of their physician maybe not knowing that they're using it or not being able to select the optimal product for what their intended use is. So that's just one thing I'll drop out there for people's consideration. Okay, so I promised you I would finish up with a case study, and we'll kind of whip through this pretty quickly so that we allow some time for questions. So our case is a 26-year-old woman who developed chronic pain after an accident at age 15. And at that time, she sustained a compression fracture of her L2 vertebra. So after this accident, she was given sort of an 8-week time frame, basically for recovery, over which the bone would heal, and then told she would be fine. Unfortunately, she experienced a gradual evolution of pain in multiple joints and muscle groups post-accident. And this, which would be no surprise to a lot of people, led to a loss of function and anxiety and depression. So during this time, the initial 3 years post-accident, she had thoughtful follow-up by her family physician, was managing the pain with fairly regular doses of naproxen and PRN use of Tylenol 3s. And she gradually lost functionality and was having some experience of pain that seemed to suggest some neuropathic components. She was given a trial of amitriptyline. So she started out at 5 milligrams at bedtime. After about a 3-week trial of this, she had no improvement in her pain and had evolved intolerable side effects, which included paranoid delusions and suicidal thoughts. So at that point, she decided to abandon it, quit cold turkey, had a few relatively minor withdrawal effects, but actually felt quite a bit better after a couple of weeks. Having stopped it, her mood improved. So given the fact this didn't work, she tried gabapentin 100 milligrams at HS and was unable to increase her dose. She had, even on this dose, had intolerable somnolence, dizziness, and inability to concentrate during the day. So this was abandoned as well. She was getting regular physiotherapy throughout this time, was going to a physiotherapist who primarily used joint manipulation, which provided some benefit, but it was always transient. And she would have the sense of things being out of position, would feel better after physio, and then would, a couple of days later, would sort of be back to baseline again. So other interventions that occurred during this period, she was referred to a pediatric rheumatologist at age 18. And there were findings of upper body joint hypermobility, but this was deemed insignificant. It didn't need any further investigation. So given the fact that she was struggling with mood and anxiety and that kind of thing, she self-referred to the BC Children's Hospital Youth Health Clinic, which is a clinic for children and teenagers with chronic illnesses. She learned mindfulness meditation, so basically a mindfulness-based stress reduction approach from one of the adolescent medicine specialists there, which she found was very helpful. Then following that, the whole family went for mindfulness-based stress reduction training, which was helpful for all. And also she undertook some cognitive behavioral treatment sessions with a psychologist. So some of the setbacks were she asked her physiotherapist about some exercises, who developed an intensive exercise program for her that she felt was safe with her, particularly with her back injury. She followed this very carefully for 1 year, and the pain gradually worsened throughout the process. Her family doctor left her practice, and she found the transition to a new family doctor quite difficult. The new family doctor prescribed celecoxib or Celebrex and regular acetylene with codeine at bedtime to try to help improve her sleep. There was some benefit, but little improvement in her function overall. And then her new family physician also left her practice, but before she did that, she sent a referral to a rheumatologist, and this was based on having done a CRP because of all her joint pain, and they found it was elevated at 8. She went several months with no follow-up after her second family doctor retired from her practice. So she tried some different approaches. She went for IMS physiotherapy instead, after having read some things about it and meeting one of her physiotherapist colleagues who did it. So she found this improved muscle spasms and neuropathic symptoms quite a bit. Was still awaiting her rheumatologist consult, and decided that she'd gone as far as she could go with cognitive behavioral therapy, and started going to a registered clinical counselor for talk therapy and EMDR to address some past trauma that she'd had as well. And felt that she started making progress again on that front with a switch in approach. So when she got to see the rheumatologist, he found significant upper body hypermobility and told her that she had less hypermobility in the lower body due to sports participation pre-accident. So basically her muscles were holding her joints together in her lower body. There were extensive lab investigations done. She was negative for rheumatoid arthritis and lupus and other inflammatory arthritis type conditions. He noted her elevated CRP, and also she had an increase in the alpha-1 and alpha-2 proteins, which are also indicative of inflammation. Ordered her an echocardiogram and referred her to medical genetics regarding a family history of hypermobility. So she's still awaiting that. She continued the celecoxib, which was fine with the rheumatologist. They reviewed her past side effects from medications and ruled out SNRIs and gabapentinoids, given her previous experiences with them. And then they had the discussion about medical cannabis. So she didn't have a family MD at this time, so she went to a cannabis clinic with a referral from her rheumatologist and was given an authorization for its use for chronic joint pain. And then she did the research into licensed suppliers for appropriate products. So what was settled on was a cannabidiol extract in oil from a hybrid strain. Her rheumatologist suggested she try a high CBD product and see how far she got with that. She started low, went slow, and determined that 30 milligrams every 8 hours was her effective dose. She found a new family physician who now authorizes it with the once yearly renewals. And she recently added THC, an extract in oil from an indica strain, 15 milligrams orally at bedtime, and gets much better sleep. And it deals quite well with muscle spasms that she sometimes has at the end of the day, and feels quite a bit better by the next day. So significant periods of time now with no pain, fewer episodes of breakthrough with increased activity. Pain that was rated probably 7 to 8 is now about 3 to 4, majority of time at 1 to 3. As I mentioned, improved sleep, continuing with IMS and counseling, and her daily meditation practice. Her physiotherapist finds that the muscles are less reactive during the IMS physio. She finds it less painful, and the benefits persist longer. She had a normal echocardiogram. She's still waiting for a medical genetics consult, and now feels able to start post-secondary education online and has an improved mood and social life. This case is my daughter, and this is a picture of her with our dog. Okay, so very quickly, resources and further readings are at the end. I have the National Academies report here, a few other papers, the Canadian Family Physician Guidelines, and some government information that's useful that came out with legalization. a couple of YouTube videos that are quite interesting by Dr. Meshulam, and also one by Dr. Carl Hart, who's the chair of the Department of Psychology at Columbia University, talking about why marijuana research is biased towards negative effects, which is very interesting. And then the Canadian Pharmacists Association resources. So you'll notice here there are two continuing education unit worthy programs that you can take online through the University of Waterloo, and you can get the details on their website. There's also some useful materials that are accessible on the website to anybody, and then the CPHA monograph that's in the CPS is now available electronically if you have access to the eCPS, but it will be in the print version next year. Okay, so there's my concluding slide. This appeared in the New Yorker the day after we legalized recreational cannabis in Canada, and I thought it was kind of a nice way to end the talk. So thank you everybody for listening.
Well, thank you so much, Terri. That was a fascinating talk. And I think we have a few questions, and so we will now go to those, and I'll read them out. Okay, so first question is, someone has heard about a cannabis patch for fibromyalgia pain and diabetic nerve pain. Would this patch also work for, oh, it's just gone. Would this patch also work for CRPS, chronic regional pain syndrome?
I think it would be worth a try. There is absorption of the cannabinoids through the skin, which is why they're looking at things like transdermal patches. And there are probably products out there that have been developed by some of the suppliers of medical cannabis, sort of in the absence of anything in the pharmaceutical industry at this point. I think a lot of the suppliers have gone ahead and done their own product development. So I think it would be worth a try. I wouldn't really be able to predict the success of it, and I don't know how effective it's been for diabetic neuropathic pain or for fibromyalgia, but I would suggest that if someone has that available to them and other things have not worked well, it would be worth a try. I've certainly had lots of people tell me anecdotally that they've obtained various topical products, like ones that are applied to the skin, that have had various types of neuropathy. Even one person who had neuropathy from cancer chemotherapy, and she remarked to me that was the only thing that actually worked. So the downside is pretty small, and I think it would be worth a try, but I would advise anybody who is going to try something like this to just advise their physician that they were going to try it, and then make sure they advise their physician what sort of effects that they got from it. But yes, if there actually is a product out there that's being promoted for those things, it might be worth trying for complex regional pain.
Thanks, Terri. Okay, and just I noticed that some people are raising their hand to ask a question, and if I could just direct those folks to the Q&A, if you can just type your question into the Q&A, then we can address them. Okay, Terri.
Yes, I see that question about the pharmacokinetics of CBD. We probably know less in general about CBD than we do about THC, but I think that the information in the monograph is kind of a composite. We can probably find out more about CBD now that we actually have some clinical trials with it. And what I would be really hoping is that now that we have had clinical trials with it and it's actually been approved for a couple of different indications by the FDA, that Health Canada will do that eventually, and we'll do some more pharmacokinetic studies on CBD as well. I mean, we do know that there seems to be an interaction between CBD and clobazam because that's a really commonly used anti-epileptic drug in children, and these studies were done in epilepsy in children. But unfortunately, CBD still remains a little bit of a mystery compared to THC. I think that it's also kind of interesting. I think one of the things that stands in our way of understanding what happens to CBD and its duration of action is that it really doesn't cause any of the psychoactive effects. So people can't people can sort of ascertain when their pain relief wears off, but most of the adverse effects are due to the THC, and they can definitely tell when those wear off. So, so I think that's kind of limiting our understanding of how CBD is handled compared to THC. So I know that's not a great answer, but I think that's about as much as we know right now.
Thanks, Terri. Okay, next, we've got a lot of questions here, and I know it's getting close to 1,
yes.
But we're going to stay on the line, and we're going to answer all of these questions.
Yes, we can do that.
And so thanks. If you need to go, thanks for participating. And I will just say that I know that this topic has tremendous interest amongst amongst everybody. And so we are going to be doing some more education and hopefully another webinar shortly on this topic. So it's a little bit of watch this space as well, because it's an unknown area. Okay, next question, Terri. Can you please comment on SSRIs and CBD interaction?
Yes, that I'm going to look at very quickly for you, because I actually have the CPS monograph here, and I'm going to check the interaction section and see if they say anything specific about the, yeah. So I did mention the fact that cannabis inhibits the cytochrome P451A2, and this actually does affect how the body handles things like amitriptyline, duloxetine, and there's a couple of other ones that are on here as well, like fluvoxamine and imipramine and mirtazapine. So basically the advice is that if a patient initiates the use of medical cannabis, to monitor the therapy for either enhanced or reduced clinical effects. We can't quantify it, so we can't just say, okay, well, if you're on duloxetine, for example, you need to reduce your dose by half if you go on cannabis. It would be nice to know that, but we don't know that at this stage. So, so what you would be looking for is if the patient is getting enhanced effects from their antidepressant, that maybe they get an increase in the side effects all of a sudden, or maybe they get decreased effect on their mood. It's very, very sort of qualitative, so it's a little hard to quantify. But you do need to be aware that there are some antidepressants, and basically it's a really good reason for a person to tell their pharmacist if they're going to start medical cannabis, because they can actually screen, based on what's in the CPS on cannabis, and then determine if any of the enzymes that we know are affected by medical cannabis are actually involved in metabolizing any of the drugs that the patient is already on.
Great. Okay, next question, and we've got 10 open questions here, so I'm just going through them in order that we receive them
as quickly as we can.
Yeah. So the next question is: does a prescription mean that Health Canada will cover the cost?
There's a couple of aspects to this. Health Canada does not cover the cost of medical marijuana for anybody. And even though it's a Health Canada program, the patient is responsible for the entire cost of it. Most of the licensed suppliers have a compassionate pricing regime for people who have below a certain income each year, or people who are on disability benefits or that kind of thing. But you're totally on the hook for the expense of medical cannabis yourself. For the prescription cannabinoids, you'll notice on that table that I had that Sativex is a non-benefit drug. So if you wanted to use Sativex, which is the THC CBD combination, again, there is no coverage of that through Pharmacare for any indication. For Nabilone, you can get it covered through Pharmacare, but that's the absolute limit of the benefits for any of the cannabis products or cannabinoids. I think there's one insurance company that I know of that will allow you to use your health spending account to cover some of the cost of your medical cannabis. And I think that's Sun Life, if I remember correctly. And there are various things in front of the courts in various provinces for people, and basically they're going after their extended benefit providers to provide some cost coverage for medical cannabis where it's been prescribe. So it has to be authorized by a physician, but it's not considered a prescription. And that's why things are all over the map in terms of the benefits that people can get. And likewise with the prescription cannabinoids, every province is going to be different in terms of what their provincial drug plan will actually reimburse people for. But Nabalone in BC actually counts towards your fair pharmacare, or would be covered on some plans where your expenses are covered. So I hope that's a good enough answer.
Great. Okay. Now we've got a couple questions about the case studies.
Okay.
So the first one is about someone's wondering if your patient is still using NSAIDs and codeine.
Yes, she is still on Celebrex. She takes no codeine now. Except a very occasional time where she's really kind of not paced herself particularly well. And she does have some, you know, relatively severe pain that pops up in a particular joint or something. And she might take some non-prescription acetaminophen with codeine, but you realize that's really low strength. And she finds that a very small amount of codeine has a pretty significant effect on her now, whereas before, 90 milligrams of codeine at bedtime was barely touching her pain. And this is something that needs more exploration, is the opioid sparing effect of cannabis. There's definitely some preliminary information that that may be the case, but it needs a little bit more rigorous investigation and some properly designed studies.
Okay, got a question from Shirley, and it's in physician shorthand here. So Terri, yes. I want you to read it.
Yes, you are correct. She is stable.
Could you read the question?
Yes. Sorry. Oh, yeah, sorry. So is the patient now stable on cannabidiol 30 milligrams every 8 hours and THC 15 milligrams at bedtime? And the answer is yes. She's quite stable on that. The last little bit of the case that I had where I sort of gave you the, you know, how she rates her pain now is, and, you know, her increase in functionality is a pretty good indication that she's quite stable on that dose. She's thinking of maybe increasing the THC a little bit at bedtime now that she's developed a tolerance to it, because she finds that the effects have worn off after 8 hours. So if she takes it at bedtime, she gets good muscle relaxation overnight with very little psychoactive effect, unless she happens to wake up in the middle of the night, in which case she feels a little bit high, but that's totally worn off by the next morning. So she's quite functional during the day on the CBD. Yeah.
Okay. Now, is there any thought around tapering medical cannabis in the case study and how one would do so?
I think we haven't really given that any thought at this moment, because although we don't have a diagnosis at this point, because she has not had her consult with medical genetics yet, her rheumatologist has basically alluded to the fact that he feels that even if she had not had her accident, she would have ended up in his office anyway. And I think that's based on the findings that she does have some markers of ongoing chronic inflammation. And also I think that, he, although he wasn't entirely forthcoming about it, the reason she's going to medical genetics is he, I think, anticipates there might be an inherited connective tissue disorder. So the impression that he left her with is that she is going to have some degree of pain likely for the rest of her life. And it's just a matter of determining what the cause is, and then they can kind of give her a prognosis as to what she can expect. So she is going to need some pain control. Everything that she's taking has had some impact, but the cannabis has had more impact than anything else. Certainly in terms of functionality anyway. So I don't think we anticipate withdrawing her from it at any point. I mean, obviously, if there was some reason why she had to, again, you know, a slow taper, I think, would be advisable, just knowing what the withdrawal effects can be like for some people and having seen them.
Terri, just sort of building on that, if where would you get information about how to taper, if, you know?
Yeah, basically, I think that probably the best information we have is to
Mhm.
try to taper it similarly, you know, in a similar fashion to how we would have a patient find their therapeutic
Yeah.
dose, and to just reverse that process. I mean, I think that's, if I were asked by a person who wanted to withdraw from cannabis, you know, for example, if they're planning on getting pregnant or something like that, I think that's probably the best advice we could give at this point is to do it slowly, and certainly over at least a couple of weeks, I would think. Other than that, I don't think there's really very much concrete information out there to go on.
Okay, thank you. Bruce is wondering if you have any comments on the percentage of people experiencing harm.
Yeah, that's a very interesting question, and there's one thing I can draw on here to answer your question is that they have found there's been a couple of studies that have looked at cannabis use disorder in people who are taking medical cannabis products for chronic pain. I think the estimates that I have seen sort of in the general population have been similar to the risk for opioid use disorder in someone who's been prescribed opioids for chronic pain. But using that as a baseline, the few sort of experiential studies that have been done is that people who are using cannabis for chronic pain seem to have a lower risk. Probably half as much or maybe even less. Now those are very preliminary findings, and again, that data is limited by the fact that the products that people use are all over the map in terms of THC and CBD content, and whether they're vaping or smoking or taking it orally. I've seen a couple of studies. There's a bunch of studies being done through the University of New Mexico where they're following people who've just gone out and got their own medical supplies of cannabis, and doing experiential studies. And the reason they do so many of those in the US is that it's very difficult to get a legal supply of cannabis and then put people on it because of the regulatory environment federally in the US. It basically prohibits that, and there's only one supplier of cannabis for research purposes, and it's way too hard to get it. So there's a lot of experiential studies coming out of the University of New Mexico, and one of the things they looked at was cannabis use disorder in people with chronic pain who were using it for that, and they found that it was actually quite uncommon for people to have a problematic use pattern if they were using it for chronic pain.
Okay, thanks, Terri. You know, and I think some of these topics, this give me lots of good ideas for some topics we can explore perhaps in future webinars. And I just want to mention, if you are wanting more information about any aspect of Terri's talk or a future webinar, if you could type that into the chat or send me an email at education@pmbc.ca. I'll keep track of that, and we'll try to address those in some sort of future education forum, maybe another webinar. So I just have, I still have a few more questions, so we'll keep going with those. I don't think we've ever had so many questions.
I see there's several from one person, so I might be able to answer those as a package, but maybe we can take this one at the time.
So someone is wondering if there are CBD creams available for sale in pharmacies. And I guess the general question is, where can you buy them, CBD creams?
Yeah, pharmacies are not selling cannabis products yet. I know that several of the large chain pharmacies are very interested in doing that, but that has not become legal yet. So basically you would be getting advice from a pharmacist based on their information they can get through the Canadian Pharmacists Association, but you would have to buy them elsewhere. So there, for example, in Vancouver, there are still lots of dispensaries that are open that existed before legalization, that some of whom have topical products, you know, ones that can be applied to the skin. And that's pretty much it in terms of being able to actually buy products that can be applied to the skin. Other than that, there really isn't sort of a legal source of those kind of things yet. The licensed suppliers are only allowed to supply dried plant products and extracts in oil. And they're usually in things like coconut oil, for example, right? And the advantage you have getting them from the licensed suppliers is that they're of known strength. You know how much THC and CBD is in each product. They've been independently tested. And they also have quality control that's very similar to what pharmaceutical companies would have. They have third-party testing for contaminants in their products and those kind of things as well. Yeah, just going and buying something in a dispensary, you're really not sure where it's come from, how much quality control there is. But having said that, there are lots of people who've gone out and bought creams or ointments or roll-ons or things from dispensaries and have found them quite helpful. It's just, you're not exactly sure what you're getting.
Okay, great. Okay, next question. Someone is sharing an experience. Marta's saying she tried a CBD hybrid oil and experienced some side effects, feeling jittery and flushed and had trouble sleeping. Is this common? Are these side effects common?
Well, CBD, definitely, you know, even if you have a product that is entirely CBD or it's mostly CBD and maybe only has traces of THC in it, the flushing and that kind of thing may have been due to a drop in your blood pressure. That's possible. The jitteriness and the trouble sleeping, it would be good to know if the product that you had was guaranteed pure CBD or whether it still had traces of THC in it, because there, I think, are some licensed suppliers that have managed to isolate the CBD almost entirely, but there are others that, you know, it'll be a CBD product, let's say, but there's 1 milligram of THC in 1 mil of oil, for example. So there's still some there. So that's a possibility. But the other thing, besides, you know, maybe some incidental THC content in the extract that you were using, is the hybrid strains are usually some kind of hybrid between indica and sativa strains. The sativa strains, despite whatever THC or CBD ratio is in them, tend to be more stimulating. And that kind of goes back to that entourage effect that I was talking about earlier, that there seem to be other compounds in the plant that modify the effects of the things that we know are the active compounds, right? So a hybrid strain, the one that you had, may have been more similar to the sativa, which tends to be more stimulating, which might explain the fact that you felt jittery during the day and had trouble sleeping at night. If you went with an indica strain, that might help. So that's something to consider, is to go with an indica strain, or if you're dealing with a licensed producer, maybe looking at some of their product information or talking to somebody at the company to find out if they have an indica strain that's similar in content to what you're taking, and that might be worth a try. So you could get some advice on that front. And to answer a couple of your other questions here, is that THC, THC actually does enhance the pain relieving effects of medical cannabis products. So, and it does have some unique actions. Obviously, you know, we were talking about how we know what receptors the THC actually hits, and that the CBD may be more anti-inflammatory than anything else, right? So adding THC into CBD usually does enhance the pain relief, and but they do suggest that you try a high CBD product and then add in the THC as tolerated to see if you can get additional benefit from it. I was listening, or I was on a webinar with the Arthritis Society a little while ago, and they had a rheumatologist talking about it, and he did mention cannabinoids, you know, on the list of things, or, you know, cannabis on the list of things that could be used for chronic pain. And he said that in his experience and in his reading, it seems like a 3-to-1 ratio of CBD to THC is what most people seem to settle on. So yeah, so the THC definitely does add something, and my other suggestion is that if you're finding that whatever product you're using is overstimulating, maybe something you might want to look at is what strain of plant your product is coming from, and maybe going more to the indica side if you find it's too stimulating, and then using the minimal effective amount of THC.
Great, thanks, Terri. Okay, on the topic of THC still, someone's wondering about if they are using THC for chronic pain, how that affects driving.
That is a hugely controversial topic right now. The problem is that there are a lot of people who really don't understand the kinetics of THC and CBD and that kind of thing, or who are thinking, okay, well, it's a no-brainer. I mean, we use breathalyzers for determining whether somebody's fit to drive or not under the effects of alcohol. Why can't we just, do a saliva concentration of THC? And if you're over a certain limit, then you're charged, right? It's not that simple. People can have levels of THC in their body that would be detectable long after they've used it. A person who's using it on a daily basis may have enough tolerance to it that they're actually not impaired after a few hours. So they may get a peak effect from THC, for example, if they take it at bedtime. It's still present in their system. It's going to be easily detectable. It could very well be over the limit, but the effects have worn off by the next morning. So how do you determine, the underlying question is, how do you determine whether somebody's fit to drive? Mm-hmm. We have never dealt with that issue, and except with alcohol, where there's a good correlation between your alcohol level and your ability to drive. But think about all of the other prescription medications that people take that impair their ability to drive. And in my almost 40 years of being a pharmacist, what we always say to patients when we hand them something we know is sedating or is going to affect their coordination or whatever, see how this affects you before you drive your car. We've never said you can never drive your car again while you're on this drug. So what, in fact, and some of the things that I've seen, that have come from, police organizations and people like that, is that we need a really, really good roadside sobriety test. And if somebody fails that, then we start looking for substances. But if they pass it, it's validated. We know that they're fit to drive if they can perform all these activities. And then it doesn't matter what you have in your system, you're fit to drive. And I'm hoping that with legalization, we actually make some headway on that. Although, as I mentioned in the talk, in Colorado, they still haven't completely sorted out that issue yet. And as you know, the case presentation I did was my daughter. Unfortunately, she didn't get her driver's license before she went on medical cannabis. And now she can't get her driver's license because there's zero tolerance for any substances in someone who has a learner's or a new driver's license. So until they actually sort that out, she won't be able to get her driver's license. So unfortunately, she's now a 26-year-old without a driver's license, which she's not particularly happy about. And she was an excellent driver when she had her learners before she went on medical cannabis. So probably better than a lot of the other drivers I see on the road. And that was on opioids, which is interesting.
Right. Wow.
So, yeah.
Complicated.
Very complicated.
Okay, we've got two more questions, and we will, and then we'll wrap up. So, someone is wondering if there are any statistics on weaning patients off of opioids and substituting with medical cannabis.
There are some preliminary studies that suggest that when people start medical cannabis, they are able to taper their opioids down to a lower dose. A certain number of them are actually able to stop them. But again, the studies that are out there have the limitation that people are using a whole bunch of different medical cannabis products, right? Or they're using cannabis from the recreational supply for medicinal purposes, right? So once we get to the point where we're a little bit more systematic and we have a body of information out there of people who are on known doses of THC and CBD, and we know what the source of their medical cannabis is and what strain it is and everything else, and they're using it for chronic pain, we can actually gather some data on how people are able to adjust their opioids when they're on medical cannabis. But there's certainly a signal out there in some of the preliminary studies that have been done that people are able to reduce their opioids once they get on a reasonable regimen of medical cannabis that they can tolerate well and gives them some decent pain relief.
Great.
So yeah, so it's promising. I can say that much.
Okay, Terri, final question. So, and I'm not sure that I completely understand this question.
Okay, I think I know what you're getting at with this question. Sativa is not necessarily THC, and THC is not necessarily sativa. So, so I'll just go through the whole thing one more time. So basically, there are kind of three different types of medical cannabis sources right now. So there's cannabis sativa, which is one strain, cannabis indica, which is another strain, and then there are hybrids between the two, right? So cannabis sativa is the one that has traditionally been used most for recreational purposes, and the ones that have been used for recreational purposes up to the point where it was legalized on the gray market were bred to have high THC concentrations because people were using it to get high. So once people started looking for cannabis for therapeutic use, there was demand for a lot of for cannabis for different reasons, right? And people were specifically looking for things that were not going to get them high, but were going to have some of the other benefits of the compounds in cannabis, right? So even in the recreational market, there was still indica strains available, and they probably had a fair amount of THC because, again, people were still looking for the high, but indica strains tend to have less of a stimulating effect and more of a relaxing effect. So people who were using marijuana to improve their sleep and things like that might have been using indica strains. So the THC is entirely independent of what strain it is. You can breed any strain of cannabis to have a high THC content if that's what the market that you're aiming your product at. The advantage to using the products through the licensed producers is they can give you an idea of the THC to CBD ratios even if you're using plant-based products, so the actual dried plant. And then if you're using extracts and oil, they can tell you exactly how many milligrams of THC and how many milligrams of CBD is in each milliliter of the oil that they're supplying, right? So, so it's kind of like there's two issues here. You can pick your strain based on what sort of overall effect you want it to have. You want it to be relaxing or stimulating. And then you select, ideally, if you are treating something like chronic pain, for example, you select something with high CBD, especially at the outset. And then you can add in as much THC as tolerated to try to enhance the pain relief that you're getting. So that's kind of where we're sitting right now in terms of, product selection and that kind of thing. The hybrids are usually the best source of information about those are the licensed suppliers themselves, because if I use my daughter's licensed supplier as an example, they have a hybrid that they have named themselves and they've developed themselves, which they have targeted at the chronic pain population. So it probably has a little bit more of the relaxing effect. They've named it canatonic, right? So it's really aimed at the chronic pain population. And in my daughter's case, she uses that strain, the hybrid strain, the canatonic strain product, as this high CBD oil with minimal THC in it. I think it has, the ratio is about 30-1. So you may as well say, it's CBD oil basically. And then the THC that she purchases is actually an indica strain because she was only going to use it at bedtime so that she didn't get side effects during the day, and she wanted as much muscle relaxation as possible because a lot of her joint pain results in muscle spasms. So she had a particular goal in mind, and she seems to have been able to address it with the product selection that she's done. So.
Okay, thanks so much, Terri, and thanks everyone for staying with us for this entire webinar. It was so useful.
And thank you for all the good questions.
Yeah, they were excellent questions. So Terri, thanks so much. We really enjoyed having you, and I hope everybody can fill out the evaluation. The link to that will be coming in along with the recorded webinar, probably tomorrow or later today. And I hope you can all join us December 13th for our next webinar. We will see you soon. Bye-bye.